So as indicated, I want to talk simply about anal incontinence, and I think the first thing I think it's important to know is the function of the pelvic floor. When we talk about the function of the pelvic floor, there are a number of jobs we ask the pelvic floor to do, and I'm going to posit that the design of the pelvic floor is imperfect. It's important. I don't know if I need to relay to you the implications of women who suffer from incontinence. I travel to Africa every year. I run a nonprofit, and we do fistula care for urinary fistula, but also rectovaginal fistula and large perineal lacerations. The debility that these women suffer without the ability to control or care for their bottoms is considerable, and it's debilitating. And some of that, although we have better coping and management strategies, is relevant even in the developed world. Up to 70% of women in the community, up to a half of nursing home residents have some form of anal incontinence, and it preferentially involves women. This is what I was talking about. The anatomy does not lend itself to durable function. All right. In terms of the prevalence, this is a cross-sectional study that was published back in 2008. These are patients without symptoms, just queried without symptoms. And what I'm highlighting for you on the left is 20-year quartiles. And then in the middle, you see fecal incontinence, and no surprise, as one ages, the prevalence increases to the fact when they're in their 9th decade, about 20% of women are describing anal incontinence and fecal incontinence. All right, so as I mentioned, we ask the pelvic floor to do a lot. We ask the pelvic floor to do a lot. We ask it to be a storage device. Both the bladder and the rectum are storage units. We ask it to empty, and we ask it to empty comfortably, completely, and when socially acceptable. We ask the pelvic floor now to pass large objects and undergo great distension and deformation. And on top of all that, it has what I call coital function or vaginal function. And that's a big ask when you think about these very fundamental and rudimentary organ system functions. And they are essentially critical to our humanness. This slide is to remind us that we are not getting younger, we are aging. Right now, we've got, a population of 320 plus minus. By 2050, we're going to hit 400 million. By 2050, we're going to have 20% of our population living over the age of 65. 20%. In 1970, it was under 10%. So we've got job security if we're in the business of caring for older people. Organ systems start to wear out and break down, and I'm going to talk a little bit about one of those things. And this is a life expectancy slide that I'll also skip. This slide is to show you that the body has designed nice structural support around our critical organs, the brain, the lung, the heart. These are all nice, firm structures to prevent injury, trauma. But the pelvic floor is full of holes, okay? Now, I am always very cognizant that what I do is not life-sparing, but it's quality of life-sparing. And my workspace is this, and this has got a lot of spaces in it. The bony scaffolding does not protect the organs that much, and it does so for a reason, because this is the outlet, and all those storage functions I was talking about, pelvic floor, this is where it all happens down here. And there's no bony architecture in the middle. It's a space. And then we add to that bipedalism. We walk upright, although we were designed as quadrupeds. This, with gravity, age, time, it's a multi-hit. And then we've got distension and deformation with larger babies, and it's a big ask. And now we're asking women to are living 40 years longer than they did just 100 years ago. All right, so you guys remember the sphincter, right? Surgically, we make a big deal that you've got a distinguished plane between the external and the internal sphincter. Our sonographers in the room also can very clearly delineate these separate anatomic structures, and this is important to us when we do our repairs. The other real important critical feature that we spend a lot of energy on are the muscles, the levator muscles that surround the pelvic floor. This here is the pubococcygeus. As we move from ventral to dorsal, it's the iliococcygeus and the coccygeus muscle. All these muscles can undergo distension and deformation. All right, so let's talk a little bit about fecal incontinence. I think I relayed to you the age relationship. It's exacerbated in the menopause. The urogenital tissues are estrogen dependent. With the withdrawal of estrogen after the menopause, they undergo degenerative changes, atrophic changes. All right, let's talk about childbirth. All right, sphincter injury happens. This is essentially the majority of women who are suffering with fecal incontinence due to anatomic structural changes. It's a result of the childbirthing process. With about 3 million deliveries a year, 540,000 injuries, if you look at estimates of 6 to 18% of sphincteric injuries, that's about over 500,000 injuries a year. If you look at some of the epidemiologic data, 50% of young women with sphincter injuries develop anal incontinence, despite proper diagnosis and repair. And I'm going to stick on this one. I'm going to distill what we're at right now, is we spend a lot of energy trying to identify sphincteric injury at the time of delivery. We spend energy trying to repair it. Even with intent and technique, we're not sure these repairs hold. So we have to be prepared that even in optimal circumstances, women are going to be left with potential structural injuries, and these structural injuries can manifest to functional problems like incontinence. This is the superficial perineal anatomy. You can see the perineal body right there between the vagina and the anus is really just an amalgamation of muscle and fibrous tissue. This is the cornerstone of the pelvic floor. During vaginal delivery, this is what undergoes a lot of distension and injury. You can even see the sphincter, the external anal sphincter even makes up part of the perineal body. And this is where you see most of the expulsive forces and the strain in this area. This is what we have lovingly called the bowling ball study. This came out of the University of Michigan in the Biomechanics Research Laboratory. They did some computer modeling. They created computerized viscoelastic bands to simulate the pelvic floor musculature. You can see the pubococcygeus, the PC, and the PR is the puborectalis, and the IC is the iliococcygeus. And as this bowling ball, which was a surrogate for the fetal head descending through the birth canal and through the pelvis, you'll see distension. That circular structure is the anus, and that U-like structure above is the vagina. So as we move down, you can see distortion and strain on the pelvic floor musculature. And when you quantify that with colorimetric analysis, you can see that the warmer colors is the greatest degree of stretch. And we saw maximal stretch almost 3 times its regular length. So if you're a physiologist and you're looking at muscle injury and the ability to repair from that, again, it's a big ask for the pelvic floor. All right. And then this is to demonstrate, although I just forwarded to you that the pelvis is an imperfect structural support, it does have lateral rigidity, and during the birthing process as the head distends, this can cause distension of the soft tissues, the connective tissues, and the nerves with either stretch and or compression injury. The compression can actually lead to anoxia, and the nerves are vulnerable, and injury to the nerves, the pudendal nerve, the sacral nerve roots that all supply the pelvic floor can then lead to dysfunction, specifically the pudendal. And then this study came out of Kaiser Southern California Permanente in the late 2000s. Dr. Lynn and I were talking how really it's the Scandinavians that lead the world with their health registries in terms of our ability to understand epidemiology and the prevalence of pelvic floor disorders, among many other things. In Southern California, the Kaiser population is relatively stable and large, and they queried their patients, and they divided these women into 3 groups: women who hadn't had babies, women who had vaginal deliveries, and women who had cesarean, and they broke the cesarean group into those who were labored cesarean or non-labored cesarean. In other words, some patients just don't get allowed to labor and have to have a cesarean delivery for either placental issues or fetal issues. And then they were queried about their pelvic floor disorders. And the take-home on this study was that cesarean group and unlabored group was very similar in their pelvic floor disorders to nulliparous patients. This is what we call an old perineal laceration or an old obstetrical laceration. You can see that there is no perineal body. The anal and rectal mucosa are communicating openly to the vagina. That's that bird beak V-like injury there at the anal, and this is what happens with unrepaired fourth degree lacerations, and this is not very common here, although we do see that occasionally when the wounds will break down. We see this more commonly in the developed world. But these women have fecal incontinence and struggle. So what do? Well, you can repair them with sphincteroplasties, and that's possible. And so that's what often gets done, not only there, but here as well. It's the most common operation for the treatment of anal incontinence and fecal incontinence, and it's often reserved for patients who have very severe, unrelenting symptoms, patients who don't want to continue conservative therapies or don't want alternate therapies with medication or physical therapy. I'm not talking about these large lacerations. I'm talking about just regular sphincteric injuries with fecal incontinence. And structural defects have to be confirmed by some sort of imaging, usually by sonography, before we'll commit those patients to sphincteroplasties. And there's two different methods. I'm going to actually not spend energy on that, but you can put them end-to-end and overlapping, and there's some discussion about what's the best way to do it. But the take-home message, as we look at our long-term data of sphincteroplasty, and I don't care if you do it overlapping or end-to-end, or if it's colorectal, or if it's a GYN or you're a gynecologist, our long-term results are very suboptimal. Our long-term results are very suboptimal. And that's 50 to 80, and when you look at the Cochrane review, it's more like 50. So I literally tell my patients, we can fix it. I can bring it together. Dr. Lin can bring it together. But long-term, 50%. And we're not sure why that is. There's some thought that it's latent injury of the pudendal. It's perhaps tissue reparative. It's muscle. Ability for muscle repair, but they're overall low. But we still will use them, particularly for those extreme cases. What else do we have? I had a couple slides that didn't get carried over. I'm going to talk about two studies. One is sacral neuromodulation. Sacral neuromodulation, it's a form of neuromodulation where we put an implantable pulse generator under the skin on the buttock area, just above the buttocks, and we put a lead into S3. It's been used for overactive bladder and incontinence. It's been used for urinary retention, and in 2011 it got approved for fecal incontinence. And there is quite a lot of data now, and multiple studies have demonstrated at least the short and even medium-term efficacy for neuromodulation in the treatment of fecal incontinence, such that it's about 75 to 80% effective in the short term. A study that got published in the Diseases of Colon and Rectum in 2014, looking at about 120 patients. They had 5 years of data. They looked at primary outcomes of improvement using the St. Mark's questionnaire, and that's basically bowel function and for both urge and passive loss of stool. And at 5 years, they had 80% of their patients were at least 50% improved with sacral neuromodulation. And then the most fascinating thing that's come out in the last couple of years is they looked at patients who had sphincter injuries. And we're still trying to understand the mechanism of neuromodulation, whether it slows motility or impacts sensation. But we know what it doesn't do. We know it doesn't fix muscle. And these patients with anal sphincter injuries seem to benefit greatly from that. So there's been a large paradigm shift in sphincteric injuries. We're no longer treating with surgery. With doing sphincteroplasty, we're offering, at least I'm offering, sacral neuromodulation as first-line option. There was a study looking with Permacol, which is a bulking agent, and neuromodulation did better than bulking agents. All right, I'm going to move on here. All right, so the next thing I want to talk about in 4 minutes is obstructed defecation. And as I sort of intimated earlier, this is normally what we consider constipation. And there's a number of causes for it. I'm going to focus in on the set of obstructed defecation that is due to anatomic cause. All right, so this mechanical outlet obstruction due to posterior vaginal prolapse, or what is in the lay public, or some older texts will refer to as rectoceles. But posterior vaginal prolapse encompasses anything that herniates into the posterior vagina. The mechanism is likely due to detachment or weakness in the septum between the rectum and the vagina, or due to perineal descent, detachment of the perineum from its more apical support structures that allow the expulsive forces not to be transmitted to the stool and the rectum, but because there's a detachment, the pelvic floor distends with those expulsive forces and doesn't transmit to the stool column. The other aspect is stool pocketing. I'll show you a picture of that. So there are some different mechanisms, and this is what you've seen as stool pocketing. So patients will strain their stool in the anal vault. Instead of expulsive forces pushing it out the anal opening, it pushes up and ventrally into the vagina, or caudally and ventrally into the perineum. And this can be easily reproduced on digital examination with or without strain. There's a number of ways that we can evaluate the posterior vaginal wall. We can do traditional fluoroscopic proctography or X-ray defecography. We can do MRI defecography. These are both effective ways, and they're used quite liberally. This can help demonstrate patients who have the stool pocketing. In other words, they're straining, and then the sine qua non is they're manipulating or maneuvering. They're either digitating rectally, they're splinting on the perineum, or they're splinting on the vagina. I would encourage you actually to query specifically, hey, when you can't eliminate and you've got to put your hand down there, where are you putting it? Because patients put it all over. They'll push on the perineum, they'll push on the side of the buttocks laterally. And have patients explain this to you? Have you actually tried to figure out the mechanism why that actually helps? It's hard to figure out pressing on the gluteal muscles actually will help impact or facilitate defecation. We can understand intravaginal splinting or perineal splinting, and then some patients don't even know to do that and immediately go to intrarectal digitation. So I will sometimes try to get them to wean off of that particular maneuver if they can, to push and press somewhere else. They'll often figure it out on their own, but sometimes they need a little advice, and it's simple advice like that. So getting back to the imaging confirmation, one can easily get an MRI or a defecography to confirm this. My caution to you is on the MRI. You will probably never have an MRI defecography without some degree of rectocele. And so the correlation, and we've done some studies looking at our relatively large group of women who have undergone MRI defecography, there is actually not great correlation with low-grade rectoceles and defecation problems. So what I'm kind of telling you is I think our grade 2 rectoceles on MRI are likely red herrings, and so if you read a report like that, be skeptical and don't tell the patient, you have a rectocele, go see Tarney. I'm happy to see them, by the way, but the rectocele may not be where the money's at. Okay. And so I'm gonna leave you with the following. For patients who have stool pocketing, perineal laxity, vaginal laxity that contribute in a meaningful way to their defecation and their obstructed defecation, we have got surgical corrections to help them with that. And we've got data to demonstrate that not only are we actually correcting the structure and restoring the anatomy, but in over 60% of the patients, not 100, in over 60% of the patients, we're able to actually improve function, and they can either reduce their maneuvering or limit the maneuvering to less frequent episodes. So I want to stop there and turn the floor over to Dr. Lin. Thank you for your attention, and I apologize for the videos.